Tak boleh lagi.
Tak boleh? Tak ada? Tak ada?
Tak ada lagi.
Tak ada lagi.
Oh ya ke? Macam mana? Baca ha? Okay, our topic today is on the urinary incontinence. Can you hear me?
Yes, Prof.
Wait.
Sorry,
Ini
Prof.
different lecture ni? Sorry.
Oh, okay.
Hey, how come we...
Boleh Prof. Cuma boleh Prof kecikkan dia punya sidebar tu. Yang
This
tepi tu.
one. Oh,
Tak
yes.
yang ada tiles tu.
Yes,
Tiles slide.
We start with our class because this one I'm not going to teach you detail. I'm just want to tell you what are the things you need to know about the topic kan. So our topic today is on urinary incontinence. So this urinary incontinence, there are a few types. First I will be talking on the general. So about the anatomy, you should know what is the normal anatomy of the female bladder, the urethra, what make the uterus sphincter, the internal uterus sphincter, the external urethral sphincter, and then what the anatomy, the structure that holding the urethra, which is urethral ligament, and then about the nerve supply, which is parasympathetic from S2 to S4, which is responsible for the bladder contraction to empty the bladder, and then about the sympathetic from T10 to L2, which is responsible for urinary storage, and then the definition of incontinence. So we define incontinence if there is a involuntary loss of urine, and it has to be objectively demonstrable, and this incontinence causing problems like social hygienic, and sometimes patient can go to depression. So incontinence is quite common, but it doesn't kill the woman, but it just steals her life. Okay, this is about the incidence. Roughly, you should just know about the incidence. For the incontinence, mainly majority involve females. And now we go to the terminology. Okay, so genuine stress urinary incontinence, GSI, is the old terminology. It's an old terminology. It is the same like the stress urinary incontinence. And stress urinary incontinence is the one that we get from the history. Patient tell you that I have urinary incontinence while coughing, sneezing. But urodynamic stress incontinence is when we do a urodynamic test and it is demonstrable that patient having incontinence from the urodynamic test. So we call it urodynamic stress incontinence. Overt SUI. Overt SUI, this terminology overt and occult, we use in a patient with a prolapse, concomitant prolapse. Patient having prolapse together with stress urinary incontinence. So overt SUI, when patient with prolapse, they also complaining of stress urinary incontinence, meaning that they're telling you. So it's a overt. But occult stress urinary incontinence, when you reduce the prolapse, you do a cough stress test. So the incontinence is demonstrable. It is occult. Normally, this occult stress urinary incontinence, what patient will tell you, initially they have overt, they have urinary incontinence, but later on when the prolapse become worse, it disappeared. This one because of the kinking of the bladder neck. So when we reduce the prolapse, then they will have incontinence. Then we call it occult stress urinary incontinence. Can follow me? Aflan. Kalau Aklan tak faham, maknanya yang lain lagi tak faham lah. Itu dia punya benchmark kan. Okay, so overactive bladder. Overactive bladder is just a collection of symptoms. It's not a really diagnosis. So this overactive bladder is a symptoms of frequency, urgency, nocturia. So frequency, urgency, nocturia. So it can be due to many causes. And we call it wet overactive bladder if patient have these symptoms and they have incontinence. Dry OAB, when patient have these irritative bladder symptoms but they do not leak, they just have the urgency but they still able to reach the toilet. So we call it dry overactive bladder. So this topic is very dry, right? Are you okay or are you already sleeping? Are you all with me?
Okay, Prof.
Okay, Prof.
Okay, Prof.
Siang, petang-petang ni dah niat nak balik rumah dah. Siapa nak balik rumah ni? Siapa nak balik kampung kan?
Tak ada, Prof.
Rumah jauh.
So frequency of micturition. What is frequency? Abir. Sian Abir, kena aja dia. What? I think I give you this topic when you are in year 3. Macam pernah bagi je. Kalau boleh bagi, kita boleh close the session balik kampung lah. Abir.
The number of micturition per day. The number of
When you say
micturition.
the patient having frequency of micturition, daytime frequency. Normally daytime lah Kalau night time tu kita panggil nocturia. How many times? If more than 7 times, right? More than 7 times, or they pass urine very frequent, more than usual. Let's say usually she pass urine every 2 to 3 hours, but recently every half an hour, sometimes every 10 minutes they want to pee. So this is what we call this frequency of micturition. Urgency? Abir, sampai you jawab, sampai you boleh. What is urgency? Urgency incontinence is when patient has desire to void, sudden desire to void, and she cannot reach the toilet. So she leaks, they pee total. Whereas the detrusor overactivity is the when patient is a UUI but is demonstrable on the Urodynamic Test. Dua beradik lah. Kalau SUI is the patient symptoms. USI when we are able to demonstrate on the Urodynamic Test. Same like urgency incontinence, UUI, when patient complain to you. And then when you do the Urodynamic Test, from the test you could see that there is a demonstrable detrusor overactivity. Then we call it DO. Okay, not okay? Okay ke tak ni kau ni?
Okay, Prof.
Okay.
Okay, cakap sikit. Okay, saya support sikit petang-petang ni. Okay, what control the continence? So to be continence, the intrauterine pressure must be higher than the intravesical pressure. This is maintained by the support of the pubourethral ligaments as well as the surrounding fascia. And the pelvic floor muscles also should be strong to maintain this continence. Okay, these are the different types of incontinence. These are a common one: overflow, stress, and urge or urgency incontinence. The other one is the functional incontinence. Why do we call it functional? Because patient physical disabilities, so she cannot reach the toilet, so she pee. So this is what we call functional. Whereas overflow is something to do with the obstruction. Obstruction could be because of the partial occlusion of the bladder neck or this detrusor muscle. There is a neurological problem. So they causing bladder atony. So bladder cannot contract. So when bladder become over distended, there will be a dribbling of urine. How do you confirm this? To confirm this overflow is by checking the post-void residual urine. We ask patient to pass urine and then we check how much is the post-void. So this overflow ni regardless of whether patient coughing, sneezing, is continuously coming out the urine, okay? Whereas the stress urinary incontinence is something to do with the anatomical defect, which is the pelvic floor. Because of the weakness of the pelvic floor or because of the urethral, pubourethral ligament which attach the urethra to the pubic bone is torn. So when there's weakness of this pelvic floor, when there's increase in the pressure, intra-abdominal pressure, so they'll be pressing on the bladder and the urine come out. So this one, the urine will come out not much, few drops. Whereas this one continuously coming out. Or sometimes when patient move a bit also, they will come out. How about this one? This one mainly because of the neurogenic, this urgency incontinence. So sometimes with the minimal amount of urine in the bladder, the detrusor muscle is already stimulated, and it wants to contract. So the muscle will contract and causing patient to have a sudden desire to void, have a very tense urgency to void, and patient can really pee, they can check betul. So the leakage too is a lot compared to this one, stress. Okay, can follow me?
Yes.
Okay, any questions so far?
No.
Sure. Aizudin, tidur ke tak? Okay, this is the definition of SUI, stress urinary incontinence. It's an involuntary leakage of urine from the has to be from the urethra, synchronous with effort or physical aggression. For example, sneezing, coughing. Sometimes patient will have leakage during prayer, when the sujud rokok tu, they leaks. Sometimes they can have what you call this sexual incontinence. During intercourse, they will have a urinary leakage. This is under incontinence. Okay. So when we talk about urodynamic test just now, so urodynamic test or urodynamic stress incontinence, when we do the urodynamic test, so during the feeling phase, you could see that there's a leakage of the urine here, leakage of urine, but the detrusor pressure, the green one, is stable, is stable. So the requirement to say that this is a USI, so when there's increased intra-abdominal pressure, there will be a urinary leakage, but the detrusor pressure have to be normal. And this should be diagnosed during the feeling phase. Okay? Too much or what? Better too much rather than little. Sian korang ni. Okay, then talking about the stress urinary incontinence, we have 3 types: stress, urgency incontinence, then overflow incontinence, and then physiological incontinence, and ada lagi incontinence, mixed incontinence. Okay, so now we're talking about the stress. Okay, stress urinary incontinence. So we have 2 types actually. One is because of the weak pelvic floor. So when the pelvic floor is weak, so the urethra ni become hypermobile. Hypermobile. This pelvic floor weak because of delivery process ke. So when there is increase in the intra-abdominal pressure here, so if the floor is strong, the urethra ni become king. But if the floor is weak, it cannot get king. Understood that?
Yes.
This is a good floor, kan? When there is increased pressure from top in the abdominal pressure, so this floor is strong, so the urethra ni can get this urethra ni can get king. because the pelvic floor will act upwards, causing kinking of the urethra. When the floor is defect, there is a tear here, so they cannot contract and squeeze the urethra. So they have a urinary leakage. Okay tak okay?
Okay.
Okay.
Okay tu, okay tu. I used to give the example like pipe water kan, water hose tu lying on the good ground kan, macam dia atas simen ya, atas simen dia punya ground tu strong. So when you press on the pipe tu, water hose tu, so it cause kinking. So the water flow stop, right? If the ground tu is strong, but if the pipe water tu is lying on the soft ground like the muddy area ke berselut tu, you step on it, when there's increase in the pressure, the water won't stop because there's no kinking. Follow?
Follow, Prof.
Okay. Janji ada seorang follow, okay lah. Okay,
Ramai pun ramai.
the other type is when there is this is a normal urethra. The other types of stress urinary incontinence, when the urethra ni, the intrinsic sphincter of the urethra damaged, so it is it looks like this. It's open. So this type we call it intrinsic sphincter deficiency. Okay. So this type of incontinence usually is very bad, very severe. Okay. Terlanggar batu pun patient will become incontinent. Okay. Okay. This stress urinary incontinence not only involve the older age compared to the urgency in urge incontinence. It can involve the young age, middle age, and sometimes during the pregnancy. Okay. And if it happen during pregnancy, normally after delivery, it will be resolved. Almost about 6 to 30% will happen. Only 6 to 34% will happen during postnatal. Okay, so what are the risk factors? This one you can read. I'm not going to talk detail because this one doesn't need explanation, right? Agree? Tak agree?
Yes, agree.
Okay, now we go to the urgency or urge urinary incontinence, UUI. Okay, so it is defined as a leakage of large amount of urine, like I just mentioned just now, at an unexpected time, which is could be during sleeping, after drinking, or listening to the running water. So there be a strong desire to void, and patient cannot defer. They have to run to the toilet. Most of the time, they leaks. Yeah. This one mainly this one it has some psychological effects. Sometimes when they hear when they see the toilet signage, they feel they want to pee. Or sometimes when they listen to the running water, also they feel that they want to pee. They have some psychological influence. So mainly is idiopathic, but sometimes it could be due to urine infection. If due to urine infection, it is temporary. Once the infection is treated, they'll be okay. Okay. Can be following an injury or post-surgery. This because of the injury to the nerve. So nerve become overactive or hypersensitive, causing this urgency incontinence. Or following strokes, other diseases, tumors, and lastly is the interstitial cystitis. This is another urinary problem. This interstitial cystitis, you know that they have the association online. IS, we call it IS. Have you come across that? Afaf, have you ever come across to this problem, interstitial cystitis?
No.
No. A lot of patients suffering from this actually in the Europe country, but in Malaysia is quite rare. So this problem actually patient will have pain during bladder filling, and then they have pain during sexual intercourse, and this one is is influenced by stress. I have one patient last time in Ipoh. Is a teenage patient. She has very frequent, very severe frequent. She has a frequency of micturition every 10-15 minutes, and it gets worse, especially when she's going for exam, sitting for exam. And it is painful when the bladder is during the filling phase. So this interstitial cystitis, we diagnosed by doing a cystoscopy. When do a cystoscopy, we could see that there's a what they call this blood and dot hemorrhage or waterfall hemorrhage. But I think this is a bit difficult for you all. I just know about interstitial cystitis. And this one, it influenced by the diet. Sometimes we take certain food, it get worse. So in fact, they have information what a diet to be taken by these people. They have a social group. Like the endometriosis, right? Okay, again, we go to the overflow incontinence. This just now I did mention about the stone, tumor. Sometimes when patient have a stress urinary incontinence, we apply the sling over the bladder neck, and when it is too tight, so patient can have this obstruction and causing this overflow incontinence. Okay, mixed incontinence is a combination of the stress and urgency incontinence. So if patient have this problem, normally we ask them which one giving more problem to them. Which component is more predominant? Is it stress or urgency incontinence? Okay. Okay, these are the basic tests we need to do for patient who comes with this urinary incontinence. First of all, we have to rule out urine infection. We have to do the urine FME. And then to rule out the overflow incontinence, we have to do the post-void residual urine. Okay. We ask patient to pee, and then we can do a bladder scan. Bladder scan, or sometimes if we don't have the ultrasound machine, we just input in the catheter, Polish catheter, to measure how much is the balance inside the bladder. Yeah. So normally, what is the normal post-void residual urine? Anybody knows? Amira? Amira? Amira tengah bakar roti kot. Anati? Semua tak ada. Anis Akila?
Maybe around 5 to 10 ml.
Sikitnya.
Not sure bro.
Some take 100 ml, some will take 50 ml, some will take 150 ml post-void residual urine. But normally what I do is that I measure how much patient pee. So if it is more than 20% of the total urine output, so I will consider as a significant PVR, post-void residual urine. Let's say patient pass urine 100 ml. So you check the balance is 50 ml. Is it significant or not significant?
Significant.
Because it's more than 20 ml kan? It shouldn't be more than 20% of the voided volume. Okay. Okay, then voiding diary. We'll talk about voiding diary later. Then we have Urodynamic Test, which is also I will be talking about it later. Okay. PET test. What is PET test? I think it's written in 10 teachers kan? Nak check lagi siapa yang ada ni ha. Fakri, Syahmi. Fakri? Ada. Can you tell us about PET test?
Prof.
Is it written in 10 teachers? Yes. What is PET test? Hafiza, Makno?
Yeah. Saya tak pasti Prof.
Tak pasti?
Tak pasti.
Kau baca ke? Oi, dia nak final pro ni.
Sorry Prof.
Siapa tahu? Akhlan.
Prof. Actually, it's we give a set of period of time, then we measure, we detect, and we estimate the amount of the urinary leakage based on the weight of the pad that has absorbed the urine after a period of time. However, it is
Okay.
not reliable to determine the causes. It can only detect and also assess how much.
Okay, Akhlan, you are correct 80%, yeah? But it's very good enough for a medical student. So PET test is just to see the severity of the incontinence, but it is not so reliable, especially in case of urgency incontinence. So sometimes we do urodynamic test, we see it is a stress incontinence, but we do not know whether it is severe or not. Yeah. So we ask patient to drink water before coming to the clinic, and then we weigh the pad, special pad, then let them use the pad. Then we ask them to do some activity that will provoke them to pee, like washing hand, climb stairs, or squatting, jumping. So after pet test, we have 1 hour pet test, we have 24 hours pet test. Normally we do just one hour pet test. So after that, we weigh the pad. But we have to know sometimes patient have a vaginal discharge as well. In case of urge incontinence, they pee, so it totally wet the pad, right? So that's why it is not reliable in certain cases. Yeah. So what is the significant pad test? How many gram that you say this is significant? Akhlan.
I'm not sure about that, Prof. Sorry.
Macam tak bela ni. It's more than 2 gram. Why we take 2 gram? Because we take into consideration of the vaginal discharge, right? So if more than 2 gram, meaning it's positive. Yeah. So for patient, let's say the PET test is 200 gram compared to those with 100 gram, we know already the severity of the incontinence. Yeah. Okay, this is the bladder diary. Is it too small? Send back go. Can you see? Boleh besarkan kan? Okay,
Boleh
this bladder diary, nampak? Can you enlarge it? Boleh kan? If you don't really see. This bladder diary, if to see whether this patient really have incontinence or not, to see whether we can do some lifestyle modification when we see the result. So because this diary, we ask patient to jot down how much they drink a day, what type of drink, and then how many times they pass urine, how much the amount of urine pass out, whether they have any incontinence, how many times they have incontinence a day, and normally we ask them what time they sleep. Because sometimes when we ask, even myself, when people ask me yesterday how much I pass urine, I don't know. And how many times I pass urine, how much I drink, also I don't know. Sometimes patient complaining of frequency of micturition because they drink a lot of water. So from this diary, we know how much patient drink, what is the recommended amount of fluid we should take a day. HICOM. HICOM ada? HICOM ke HICOM? Hidayah?
Maybe 1.5 liter of water.
Yes, good. Yes, 1.5 to 2 liters. If she drinks 3 liters a day, so we'll advise them to reduce the amount of water intake, right? Minum banyak, kencing banyak lah. Okay, and then type of drink. If they drink coffee 5 times a day, definitely they will have a frequency. So we advise them, if they really cannot live without coffee, so they can drink coffee once a day. So this is very important. And we can count how many times they pass urine and then what time they sleep. So after sleeping, so that is considered nocturia. How many times they have nocturia. Okay. So this bladder diary is important to diagnose whether the urinary problem. Second is to see the response towards treatment. We do this diary before treatment and then after treatment. Okay. Okay, other tests can do that is that a renal function test. This one is very seldom unless we suspect that patient has renal impairment. This pelvic floor ultrasound is also important. We need a special ultrasound machine and a special person to do it. We can see whether this is because of bladder neck hypermobility, whether there's any concomitant prolapse which is not seen by naked eye. Cystoscopy is not indicated in all cases except when patient has interstitial cystitis or the complaint of hematuria. Yeah. Video cystometry when patient when we do urodynamics, we cannot demonstrate the leakage, so we do a video cystometry. And also for a patient with diabetes, we suspect that patient might have a neurogenic bladder. So intra IBU also is seldomly done. This pelvic ultrasound, not pelvic floor. Pelvic floor and pelvic ultrasound is different. Pelvic floor ni is just a pelvic floor. Pelvic ultrasound we do also. Sometimes if patient requires surgery, they might have other concomitant annexal masses like ovarian cyst ke apa kan. So it will alter a bit of our management. Okay. So these are the urodynamic machine. Have you seen our urodynamic machine in the clinic?
Yes.
Yes.
Okay.
Yes, Prof.
Yes.
Okay, good. So we'll do the urodynamic test. If diagnosis is not clear or patient with OAB symptoms and we treat them with medication, they fail, they did not respond, or we suspect that patient have neurological disease or patient with prolapse going for surgery and they have the urinary symptoms. If patient with stress urinary incontinence, which is pure stress urinary incontinence, they're going for surgery and we are very sure that there's no other problems, we might not do the urodynamic test. It is not compulsory. But if the service is available, we can always do. Okay, this is an example of the urodynamic test result. So if you see here, what are the pressure measured during the urodynamic test? And how to measure it? Can you tell us, Muhammad Iqmal?
Hello, Prof. I've seen one, but I'm not really sure my answer, but I'll try.
Just
If I'm
want
not mistaken,
to check on you lah, whether you're following the lecture or not, yeah? Because
Alright.
this online, people can just on it and do other things.
if I'm not mistaken, the pressure that they measure is one of
Natasha,
them.
lama tak panggil Natasha. Mana dia? Saya balik Kelang lah.
Hello, Prof. Can you hear me?
Natasha. Mana Natasha?
Hello, Prof.
Asfar? Asfar is not in this group. Rahil? Okay, since there is no response, I just
Yes,
continue. We can finish it early. So, okay, for the urodynamic test, what are the pressure that we are measuring is the vesical pressure, which is in this blue, vesical pressure. How to measure this vesical pressure? We put in the catheter into the bladder, okay? The other one is the abdominal pressure, which is in black, this one, which is in black. How do we measure it? We can put in the rectum. We can, if patient has colostomy, stoma, we put in the stoma. or we put in the vagina. But in case of prolapse, we can't put it in the vagina. So under the green one is the detrusor pressure. This detrusor pressure is not a direct measurement of the pressure. It is a pressure when we do a subtract from the vesicle minus the abdominal pressure. So we got it the detrusor pressure. So in case of detrusor overactivity, we could see the leakage, and the green one also naik, like a wave. So we call it detrusor overactivity. But this one, the detrusor is stable, but this one patient leaks. So this is a case of stress urinary incontinence. Okay, for the stress urinary incontinence, the treatment we have two treatments modalities, non-surgical and surgical. Okay, so normally what we do is that we have to start with the conservative treatment, which is a pelvic floor exercise for at least 2 months. If there's no improvement, then we proceed with the surgical treatment. Okay. Other non-surgical treatments include these drugs which is not reliable at all, and intravaginal device also is not really, showing the very effective. So what we normally advise is the pelvic floor exercise or Kegel exercise. Okay. And this is for the urge incontinence. So we should differentiate between the stress urinary incontinence and urge urinary incontinence because the treatment are totally different. If it is urge incontinence, treatment is mainly the conservative pharmacological and the behavioral modification, like reduce fluid intake, avoid liquid during night. Before 2 hours before going to bed, we advise patient not to drink. And then we ask patient to do a bladder retraining. Let's say if she feels that she wants to pee, she can hold first for about 5 minutes. While holding the bladder, she can distract herself by sitting at the edge of the chair, or she can squeeze the ball just to divert her mind. Okay. So after sometimes if she's comfortable delaying for say about 5 minutes, then after that she can pass urine. So then the following week she can increase the interval. Maybe she increase to 10 minutes until she can hold her bladder up to 2 to 3 hours. Okay, so this is what we call this bladder retraining. Okay, and the pharmacological mainly is the antimuscarinic or anticholinergic drugs. For example, oxybutynin, which is a very old drugs. And then the totoradine. The latest one is the mirabegron. So we should know what are the receptors over the bladder in which this drug is acting on. So for the mirabegron, it is a what drug is this? It's beta 3 receptor. It acts on the beta 3 receptor. Whereas all these anti-adrenergic or anticholinergic drugs, they have a lot of side effects. For example, dry mouth, constipation, dry skin, and it is contraindicated in the patient with increase in the intraocular pressure. Okay. This is the conservative treatment we did mention just now. Okay. Patient with stress urinary incontinence, there is also a role for the conservative treatment, especially for those who are still planning for the future pregnancy and who's has not completed their family and the symptoms is not serious enough for surgical intervention. Okay. Okay, these are the behavioral modification. We ask patients to stop smoking. Those the things that causing an increased risk of. This one is mainly for the incontinence and some effects on the stress. Minimal things to do with the stress incontinence. Okay. This is the pelvic floor training, PMFT, bukan terapi, pelvic floor muscle training. The basic thing is the Kegel. But in patients who are not very good doing Kegel, sometimes we can give them, we can have something to support as an adjunct to the Kegel. For example, biofeedback. Biofeedback, we can put this probe in the vagina. So there'll be something coming out in the computer. Patient can see whether they're doing a correct Kegel exercise. Or sometimes the pelvic floor muscle is very weak. They cannot contract on their own. So we can put in the electrical stimulation. So this is a passive exercise. So the, the electric stimulation can cause the muscle contraction. After sometimes when patient able to do themselves, then we can ask them to do a normal Kegel. So this Kegel, we have two types, the slow contraction and the fast contraction. The fast contraction is very beneficial for the stress urinary incontinence because this pelvic floor, we have two types of muscle fibers. The fast acting fibers and the slow acting fibers. So we ask patient to kemut lepas. That is for 10 times, and then for the slow one, ask them to squeeze and hold, count for 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then release. So this one they have to do it regularly. Okay, these are the drugs for mainly for OAB or urge incontinence. Mixed incontinence, normally we ask them which one is more severe. Normally we give a medical treatment first. If it doesn't work, then we proceed with the surgical intervention. These are the other examples of the adrenergic or anti-muscarinic drugs, which is useful for the overactive bladder. Okay, if patient have prolapse together with stress urinary incontinence, when we reduce the prolapse, patient will complain of urinary incontinence. This is the reason why they are not compliant to the pessary. So the other alternative is that we can put the pessary with this knob, what we call this incontinence pessary. This knob, we apply over the urethra. It has to be underneath the urethra. So when patient coughs, there is something to support the pelvic floor. Okay. This Botox not only for beautician to look young, to inject on the face, but it's also beneficial for the bladder in case of bladder urinary urinary incontinence, especially the wet one. We inject Botox into the detrusor muscle. So this is to cause paralysis of the detrusor muscle so that it won't be so active and always contract the bladder. But this one is not permanent. After 3-4 months, patient requires another injection. Okay, the surgical therapy, this is for the stress urinary incontinence. So just now I did mention that because of the pelvic floor is weak, so we need to stabilize the pelvic floor. How to stabilize the pelvic floor? We can put this, we can do this surgery either by abdominal approach, which is retropubic urethropexy, or vaginal approach, which is a sub-urethral sling. Okay, this is an example of the surgery for the stress urinary incontinence. It can be done as open laparotomy or laparoscopic. This is, they enter the radial space and they look for the corpus ligament. This corpus ligament will be sutured to the vaginal wall. So it will elevate the bladder neck. This is the whole of surgery. This one you see, the birch corpus suspension. These are corpus ligaments. They attach to the vagina to elevate this bladder neck. Okay. And this is the modern one, which is mid-urethral sling. What they do is that they put this mesh materials, which is similar to the mesh used in the herniorrhaphy. which is made of the polypropylene. This sling can be made of the facial latex, which is bio type, biograph. So this is tension free. There's no attachment anywhere. You just put underneath the mid urethra. So it can be retropubic, which is it come out suprapubically, or transobturator. We apply and it come out through the obturator foramen. This is like a hammock type. Okay, I'm not going to detail about this unless you all ask me. Okay, so this is example of mid-urethral sling. We have TVT, we have TVTO, we have TOT. Nowadays, I'm using this Coloplast. Okay, that's all. Dah siap, on time tak? Ada 1 minute lagi for question.
Prof,
Prof?
Prof dengar tak?
Any question?
Oh, Prof tak dengar.
Faham ke tidak ni?
Assalamualaikum, Prof. Can you hear?
Nabila,
Prof tak dengar.
tak dengar?
Okay. Prof, can you hear us?
Ya. Tak dengar ke?
Prof boleh dengar ke?
Saya tak apa dengar sangat. Ada je ni. Tak dengar?
Prof?
Prof dengar ke sekarang?
We can hear you, but can you hear us?
Tak apa dengar?
Prof boleh dengar ke kita orang cakap sekarang?
Sikit-sikit je. You all can hear me or not?
We can hear you.
We
Tapi
can
Prof
hear
boleh
you
dengar.
clearly, Prof.
Okay, I'll try to listen to you all. Okay, any question?
I got one question. Okay, so just now you said that initially we treat the patient conservatively. So after we advise the patient the diet, the exercise of pelvic floor, so how long do we need to monitor the patient before we starting on medications on pharmacology or surgical intervention?
Okay, very good question. You see the patient, if they come with very severe symptoms, crying to you, are you going to ask them to advise on diet? No. If it's just a mild symptoms, maybe you can just try on diet first, do exercise, reduce your weight, stop smoking. But those with very severe symptoms, we do together. We put them on pharmacotherapy. This one we're talking about the overactive bladder lah, ataupun urge incontinence, and then we modify their diet and then do exercise. We do all together. Same like the stress urinary incontinence. Let's say we think this is a intrinsic sphincter deficiency in which the sphincter, intrinsic sphincter is damaged. Can we ask them to do exercise? Definitely cannot, right? So straight away we subject them for the surgery. Okay? So it's a case by on the case basis.
Okay, understand. Thank you.
But the nice recommendation is the conservative treatment first 2 months. Why 2 months? Because this pelvic floor, it takes minimum of 2 months to build up the strength. Okay, good question. Any other question?
Thank you, Prof.
Welcome.
Prof, I want to ask regarding IST tadi, because macam if tadi Prof kata SUI we have two types. Yang weakened floor tu we can do the sling and corporal suspension, but for IST any other surgical intervention for?
Okay. Oh, my slide tak ada bulking agent je.
Tak ada.
Tak ada. So for the ISD ni, normally it's very severe lah. We don't recommend pelvic floor exercise. We can do sling as well, but it's a retropubic type, not the obturator type. Yang tadi tu kan. We do this type, sling. Then the other thing we can do is that we can inject this bulking agent into the urethra, because the urethra is like macam open up macam tu kan. So we inject the bulking agent so that it cause like macam it's narrow the opening of the urethra. You form an coaptation so that they won't leak. Okay. If in a worst scenario that also fail, we can put the artificial sphincter. Okay.
Oh, faham, understood. But for yang urethral bulking agent tu, macam they need frequent
Bulking
injection.
agent tu kita pakai cystoscope, kita inject. And that one is not permanent, same like Botox lah. After sometimes after 4 or 5 months we can inject lagi. This is what we call is bulking agent. Because in US, in UK nowadays dia dah tak pakai sling, tak pakai polypropylene mesh because a lot of medical legal case using of the mesh materials ni, patient banyak sue. So now dia dah move towards the bulking agent. Even hypermobility pun dia pakai bulking agent. Dia tak pakai sling dah.
Alright, understood. Thank you.
Okay, welcome.
Prof Zalina.
Yeah.
Saya nak tanya, currently hysterectomy is also a choice of treatment?
Hysterectomy? No, not at all.
Okay.
That one is for prolapse. Hysterectomy not a choice at all. Hysterectomy can lead to incontinence.
Okay, Prof.
Any other question?
Prof, may I ask, regarding the role of urine Euroflow meter, how does it aid our management, Prof?
Euroflowmetry, free Euroflowmetry or Urodynamic Test?
Euroflowmetry, Prof.
Free Euroflowmetry, because Euroflowmetry is just to see the urinary stream kan, how is the maturation without, this is like a screening test prior to Urodynamic test. Free, nama pun free kan, so there's no pressure measured, just to see how is the maturation. So we ask patient to pee, so we measure how much she voided, how much is the residuals, and then how about the maximum flow, Qmax. So if the Qmax is low, could be there's some evidence of obstruction. But because sometimes when we do urodynamic test during the micturition time, there's a catheter inside the urethra, so patient cannot pee. But the advantage of this, we can measure the pressure during the voiding cystometry. So this free Euroflow meter is like a screening test, and it's very useful in male patient which is having BPH kan, to see how much is they have this obstruction, right? But this free Euroflowmetry, the amount of urine in the bladder should be more than 150 mils or 200 mils. If there's small amount of urine in the bladder, definitely the stream tu is not strong because kecil je kan. Air sikit dalam tu dia keluar kecil je lah. So it's not reliable to interpret if the voided volume of urine is less than 200 mils. Okay, Aklan, did I answer you?
Yes, Prof. Prof, meaning that before we do UDS, we do the Euroflowmetry. If it is normal, then we don't need to proceed with UDS.
Sorry?
If the Euroflowmetry is normal, do we still need to proceed with the UDS?
Yes, definitely. This is just a screening test. Definitely, we still have to do.
All right.
Because it doesn't tell us anything about the pressure. We wanted to see the detrusor pressure as well, right?
Yes, Prof.
And then to see the stress urinary incontinence, because during free Euroflowmetry, we don't ask patient to cough or do anything, right?
Okay, thank you, Prof.
Okay, any other question?
Prof, I would like to ask about the incontinence pessary. Does it mean when the patient on pessary, they have a risk to get the incontinence as a new symptoms, isn't it?
Yes.
And
especially in case of occult. Initially, they don't have urinary incontinence, but when they use pessary, because the prolapse is already reduced, then they become incontinence.
Okay.
Actually, they ada because of the prolapse is too severe, make them continent. Actually, they too incontinent.
So actually, how we want to differentiate? Is it because of the pessary that cause incontinence, or they actually fail the pessary and the severity of the product has been progressed?
No, the pessary doesn't cause incontinence at all. But we do have incontinence pessary to prevent incontinence.
Okay. Alright. So it's not
So the
there is
complication of pessary is not the urinary incontinence. But the incontinence the patient already have it's just that being masked by the prolapse. Okay. So when they put in pessary, the prolapse is reduced. Okay. So they become incontinence. Faham tak?
okay, faham.
Any other question?
Prof, after the I want to talk about the POP. Sebab after hysterectomy, there is also have a boleh ada recurrence of prolapse, tapi saya macam pelik sebab dah buang dah, apa yang nak prolapse ni lagi, Prof?
Okay. Buang tu uterus.
Oh, okay.
What is a prolapse? Prolapse is because of the weakness of the supporting structure of the vaginal wall, kan? Bila vagina tu prolapse out, so what will happen? The one which is attached to it, dia kan ada anteriorly is bladder, apical is uterus, kan? Proof dia posteriorly is the rectum. So when the vaginal wall prolapse, so all the structure follow. So when you remove the uterus, did you remove the vaginal wall? Tak, kan? You just repair the vaginal wall. So that's why they can recur. What we are repairing is the weak structure. We repairing the weak structure. So the recurrence is very high. Why they prolapse? Because all those supporting structure is weak. So if we want to do repair for prolapse, if we don't want to remove the uterus also, it's okay, it's fine. Uterus is innocent. We can still keep the uterus, yeah? No issue.
Okay, thank you, Prof.
Okay, good question. Any other question?
Prof, regarding the diary just now, you mentioned that it is done to confirm the incontinence, or if it is rather than being a secondary cause from increased fluid intake and so on. May I ask, from the diary itself, can we differentiate between stress or like urgent incontinence, Prof, from the diary?
Can. Because from the bladder diary, right?
Yes, Prof.
Bladder diary. So we in the diary, when they become incontinent, we did note there what they did during that time. Is it coughing, sneezing? So we can know roughly. Is it because of stress or because of urgency?
Alright, Prof. Thank you.
Good response. At least you know. I mean, you all understand what I was talking just now. Okay. Any other question? Okay, if none, we close this session with reciting Surah Al-As, yeah? Okay, have a nice weekend. Assalamualaikum.
Thank you so much, Prof.
Thank you, Prof.
Welcome.
Thank you, Prof.
Thank you so much, Prof.
Welcome.
Thank you, Prof. Zalina.